signed on as my daughter's name. It is me, Anisha, I promise. Charlotte sends her apologies today, so she won't be joining us. So we're very pleased to have with us today Dr. Ash Sani, who's a consultant radiologist from the Royal Free, and Dr. Felusha Aluwajana, I'm really sorry if I've said that wrong, an Islington GP and a clinical lead, who'll be talking us through the new non-MSK ultrasound guidelines. And these are being launched across NCL and being promoted via the British Medical Ultrasound Society and via NHS England. So it's really important that we're all sort of on top of it and that we're all aware of these new guidelines. And they've been ensure that these guidelines are aligned.
Anisha, we've lost you.
Okay, whoever's on, is someone on? Oh God, I need to.
Anisha, we've lost you.
Anisha.
So.
Okay, Sam, can you stop playing?
Oh dear.
Someone needs help.
So can I ask Dr. Aluwajana to introduce herself? Terribly sorry. I know that Anisha was about to introduce you. So do you want to introduce yourself? You're on mute.
Well, so many technical difficulties today. I'm Felusha Aluwajana. I'm a GP in Islington and also Islington Pathway and Redesign and Implementation Clinical Lead. And I'm working with the clinical working group, which does include Ash, the radiologist from Royal Free, on the new guidelines for ultrasound, routine ultrasound referrals across NCL.
Wonderful. Thank you very much. Anisha, you're back.
Hi, I'm so sorry about that. Obviously very dodgy today, so I'm really sorry. Thanks, Anita. I don't know how much of the introduction everybody heard or where everybody got to.
We've just introduced Dr. Aluwajana. I'm sorry, I'm not so sure whether I'm saying it correctly.
Aluwajana, yeah.
Aluwajana, brilliant. Yeah, thanks so much to our, because I'm really sorry about the Wi-Fi connections. Thanks so much for our clinical team for joining us today to talk us through the new non-MSK ultrasound guidelines. So we look forward to hearing updates on those because they're being promoted via the British Medical Ultrasound Society and NHS England. So it's really important that we're all aware. And the clinical team have worked hard to align these with key clinical pathways across NCL, and they'll be talking us through clinical scenarios and examples of referrals today. So we look forward to that. And we'll also have our usual Federation Training Hub and Medicines.
You've just been muted. Wasn't me this time.
I keep being muted because I'm not logged in as Anisha. I'm really sorry about that. So I hope everyone had a very relaxing bank holiday, Easter break. And I'm now going to hand over to Anuj from the Federation. Thanks, Anuj.
Hi, Anisha. Sorry, it's Ray here. I'm coming for Anuj today.
Oh, sorry.
That's okay. That's fine. Okay.
Sorry what you did say. Thanks, Ray. Thanks for covering.
That's okay. Yeah. Sorry. Yeah. So if you could just go over to the next slide, please. Yeah, so just a few updates from ourselves. So for EHS, this is the extended hours service, which is part of the DES, also previously known as the community clinics. These are namely composed of HCA nurse type appointments. The Federation has communicated with the PCNs and practices with an advised offer. We're currently collating Q4 data, which will be validated and shared with CDs and PCNs. For our anticoagulation service, we've been fully operational and continuing to run out of 4 sites. Details are below. If I could just get the next slide, please. So new services update. So far, in terms of rapid response, are very positive. Thank you to all the member practices and GPs who came forward to provide the service. The service has been extended till June. Discussions are ongoing with CLCH about longer term arrangements, which will communicate with practices when agreements are in place. For the care home, this service was well received and decommissioned on the 31st of March. If I could just get the next slide, please. So the GP support to Barnet Hospital commenced on the 2nd of February and the rota has run its course till 31st of March. In terms of our in-hours service, we continue to offer an in-hours remote GP service to practices that may wish to purchase these sessions. We've been supporting a number of practices in this way over the last few months, particularly those affected by staff being off as a result of COVID. If I could just get the next slide, please. So in terms of our extended access updates, sorry, I just lost it there for a second. So our planned activity is 4,465 appointments for this month, which obviously included the bank holiday. Just recently, invitations have been going out for the task and finish groups with the CDs and business managers. So just a polite reminder that to respond to that so we can get a meeting booked in. There's also a piece of work where we're recruiting salary GPs to work predominantly in the EAS service. So if you're interested, please do email us. We'll just go to the last slide. And that's it from me. Thank you.
Brilliant. Thanks, Ray. Thanks for that update. We'll just move on now to a quick Training Hub update. So the first quick thing from me is a message from Will Mayer, who is one of our clinical leads who's been in charge of the induction pack. Everyone aware that there is this induction pack that's available for all new primary care staff in Barnet, and it's a risk.
So can I just finish off? So Will's created the induction document, which is a written document, which is fantastic. I've had a look at it, and thanks to Will. I know you're on the call, Will. I don't know whether you want to unmute and say something about your induction pack to the audience. Okay, Will's not able to. So the induction pack is there for any new starters. So please, if you've got a new starter, can you send Emily on CEPN admin an email who will send you the induction pack. The induction pack has lots of information about the IT, EMIS, AccuRx, how to use that, including PCNs, who the clinical leads are, tells you a little bit about the geography of Barnet. It also tells you about what the induction should look like within practices. So it's a very good document. So do send all your new starters to email addresses to Emily, who will then forward the induction document to everyone. And also with regard to the new starters, for example, the care coordinators and the pharmacy technicians, Will is doing some Zoom induction as well. So so there is induction for additional roles that will be doing throughout the year as a fellow. Thank you.
Thanks, Anita. Thanks, Anita. I've joined back on my phone. I'm really sorry about the Wi-Fi connection. I came home from clinic, especially to get better Wi-Fi, but it hasn't worked. Yeah, so thanks, Anita. Will's induction is brilliant. He's forwarded me the document, and it's really detailed. It's really comprehensive. So it's definitely worth getting in touch with the Training Hub. It'll be Em's email address. Em, if you can pop your email address in the chat for us, if you have any members of staff who that would be relevant for. I'm now going to hand over to Chaz from the Training Hub to update us about physician associates, PA. So over to you, Chaz. Thanks so much.
Thank you. Yes, and it would also be very grateful if I could get a copy of the induction pack as well. That'll be useful. I'll time myself, as I understand you're quite pressed for time, so I'll give myself 3 minutes starting from now. So as you can see from the first slide, I'm the lead PA ambassador for Barnet and Enfield, and I kind of help with CPD teaching environments for PAs working across London. I'll also be helping you guys support PAs and also support PA students that may be coming into your practices from the next academic year. My background is that I initially worked in NHS management for around 5 years from 2007. And then I started the PA course in 2012 and graduated in 2014. Since then, I've been working in urology in St George's Hospital for the last 6 years, and I'm also a lecturer on the PA programme. Next slide, please. So as you can see there, I graduated from my undergraduate degree in 2007, and I also founded what was called London Affiliation of Physician Associates in 2018, which is a organisation that helps support PAs, but also employers. Every month we have a teach-in which we accredit, which is accredited by the Royal College of Physicians. So we have 1 hour of CPD, which is type 1. We also have Tong, who is the other PA ambassador for Barnet and Enfield, and she qualified in 2020. She currently works in Enfield and Carlton House Surgery, and Tong has been an important member of the staff working in the COVID vaccination programme in Enfield. Before that, she was a nurse, and she qualified from the University of East Anglia. Next slide, please. So in terms of physician associates and what we can do, we are dependent clinicians and we can practice independently with the collaboration support from clinical supervisors. We can be found working in GP surgeries, A&E departments, and inpatient medical and surgical wards. We provide we're the kind of first point of care for patients presenting with undifferentiated diagnosis, and we utilise history taking, physical examinations, and clinical decision making skills to establish a working diagnosis. Essentially, we're an extension to the medical workforce. Essentially, in terms of enabling the role within the Barnet and Enfield region, or specifically in the Barnet region, we're keen to kind of develop student placements within this region. There are over 34 universities undertaking the PA role across the UK. The nearest university is the University of Hertfordshire, and they run a 2-year MSc course, which I'll be circulating to all of you guys. They run a 2-week placement for the first-year students and a 7-week placement for the second-year students. And again, I'll be circulating that information to the Barnet region. In terms of the additional role reimbursement scheme, PAs were added to the additional role reimbursement scheme last year, and we will be, sorry, that's my timer going. This, in terms of the on cost, you get £53,000 for the additional role for the ARS scheme. And again, I'll be sending that more information regarding that. In terms of employing physician associates in the first year, we're keen to kind of develop a preceptorship handbook and scheme for PAs across Barnet and Enfield. This scheme will enable qualified PAs to undergo clinical supervision in terms of teaching and training in their first year, but also give a kind of safety net environment for employers as well as the PAs. Next slide, please. We have a primary care event hosted on the 13th of April. And this is a kind of free online workshop for potential employers of physician associates. There will be talks from PAs who are already established in primary care, but GPs who currently supervise PAs. And there'll be an opportunity for question and answers at the end. The link is provided as in the presentation. I can put it in the meeting chat in this chat bar, if that's okay. And I think that's about it. My contact details are there, and my email address and my contact number. But if anybody has any other questions, I'm more than happy for people to ask me. I think I've just gone over 3 minutes.
Brilliant. Brilliant. Thanks, Jazz. Thanks so much. It was really useful to hear about your role and what you do. And great to have your contact details just in case people want some more information. So thanks so much for that update. I noticed some of our NCL colleagues have joined, so welcome to everybody. I'm just going to hand over to Suzanne Lever before we hand over to the ultrasound team for a quick medicines management update. Hi Suzanne, thanks so much for joining us.
Thank you. If I could have the slides, please, that would be amazing. Thank you. My first happy Easter, everyone. Hope you did manage to get a break. First point I wanted to mention was the North Central London prescribing recommendations. It's very exciting that these are now North Central London wide, and what these aim to do is standardise medication choices, outlining preferred choices for treatments in primary care, What I would say, it doesn't cover all areas, and this list it's not restrictive. So if you need to prescribe outside of these, that's absolutely fine. It just gives you an outline of the preferred choices. This the NCL prescribing recommendations we refer to them as the NPR, are based on the Camden guidelines, which have been around for about 12 years. And Haringey adopted this a couple of years ago, and said it worked very nicely with ScriptSwitch, which is why we've rolled this out right across North Central London. It can be accessed via the NCL GP website, which I do suggest you register and log on to that so you can access them. And it follows the BNF chapters. And what's good is in each of the chapters, the supporting documents from either from NICE or from the JFC recommendations or local pathways are actually included as well. So it's a sort of a one-stop shop there. We are aligning this to ScriptSwitch. We will be working on this in the future with further plans to integrate ScriptSwitch into this more. The NPR is intended to be imported onto EMIS Web, so it will look like a formulary with the choices that with the recommended choices outlined in black. And the other choices sort of greyed out, but I would also emphasise they can still be prescribed. Controlled drugs really can't be included because they are red, and that's just part of EMIS. So we can't actually specify any choices for controlled drugs. There we'd need ScriptSwitch to sort of come in and help with for example, the preferred brands. So hopefully this will be another tool to help to standardise treatments across the patch. And we would very much welcome any feedback or comments that you have. This is a work in process, and we do plan to sort of integrate this further as we go along. I think one of the areas where it will be really helpful is, like, for example, in ONS choices for Ensure Plus, there's a list as long as your arm and different formulations, but this will actually give you the correct formulations that are on our formulary and make it a bit easier. So hopefully it will help in that regard. Can I have the next slide, please? The next new area for us is Prescribing Watch, which is coming from May 21. And this is a monthly medicines optimization update, a newsletter, and it's based on the existing Camden and Haringey medicines management updates, but we're working together across North Central London to all contribute. And this will have summaries of guidance, national guidance, NICE, MHRA alerts, joint formulary decisions, local prescribing guidelines, as well as supply issues. So everything all in one place every month, and hopefully you'll dip into this and it will be helpful, and that will be circulated to all. And the next slide, please. I just wanted to mention emollients and the fire hazard risk. I know that we've discussed this previously, and there was guidance that came out by the MHRA which said it was mainly products which contain more than 50% paraffin. That's actually been amended now, and really the risk is with all emollients, including those which are actually stated as paraffin free, as they can also be flammable. I think the main message is really to make sure that patients and their carers understand that if they use these creams, that they can build up, and the residue on their clothing or bed linen or even on their furniture, if it builds up, it can become a fire hazard when exposed to heat sources, cigarettes, candles, etc. And that's the main message. And this was actually an MHRA alert in July 2020. So I thought I would highlight it because unfortunately there was a very nasty incident a couple of years back with a care home resident who unfortunately lost his life while smoking and having had emollients applied. The next slide, please, is the last one is actually on hay fever, and it's just hopefully a timely reminder that please advocate self-care where possible. We're currently looking at, we currently spend about £250,000 a year still on products for mild to moderate hay fever, and these should be prescribed. These should be bought over the counter. They can be bought in pharmacies, supermarkets, etc. But obviously there are still some patients who do need them prescribed, and if if you feel that actually their ability to self-manage is compromised, say for example mental health or medical issue or significant social vulnerability, then please do continue prescribing, but all others really should be directed to their community pharmacy. And just to say, it is possible to spend less. Enfield spends about 40% less than Barnet Borough per 1,000 patients on these products. We're certainly not the worst borough, but there's always room to try and help and reduce spend in this area. And this is actually an NHS England recommendation, a national recommendation. So thank you very much. That's for me. Very nice to see you, and thank you for your time.
Thanks, Suzanne. Very helpful update as usual. Very useful reminder about emollients, and useful to have that information about Enfield as well. Suzanne, a question from Andrew. Can we change from the Freestyle Libra 1 to 2, or does it need to be done by secondary care? Does the change need to be done by secondary care?
I think the main issue there was that actually just to make sure that the patient knows what's happening. If this is usually it's instigated with secondary care, then the patient actually gets the right kind of training, because there are different things like alarms, and the patient needs to understand how to actually use those and set those up in order to use it effectively. I think our guidance was wait for sort of an NCL guideline on this, but if you have got a patient who really knows what they're doing and is very informed, etc., then you know, it is possible, but our main recommendation is to wait until it's sort of introduced in secondary care. And I think we were waiting for some training guidance from Abbott, and that hasn't been forthcoming, but I will update you and send out a communication regarding this. Thank you.
Thanks, Suzanne. We don't want to take up too much of the next speaker's time. There are a couple of questions in the chat from Stephen Corcoran, Jonathan Lubin, which I might ask you later for the answers, Suzanne, and circulate later if that's okay. Brilliant. Thanks so much. Great. So we'll move on to non-MSK ultrasound guidelines now. I'm very happy to welcome Ash and Felicia to our talk today, who have been the clinical leads on this project and will tell us all about the new guidelines. So Ash and Felicia, over to you. Thanks so much for joining us.
Okay, sure, TK, that's fine. I'm just finishing off bits and bobs. I'm trying to do as much as I can before coming home.
Hi.
Oh yes,
and also just to say, if you're not speaking, just make sure you're on mute, please. Thank you.
Hi, I'm Felicia Oljana. I'm GP from Islington and the clinical lead for Pathway Redesign and Implementation. And we have Ash, I think, on the call somewhere. I'll let him introduce himself again.
Hi everybody, my name's Ash Saini. I'm an interventional radiologist at the Royal Free Hospital, and I am the NCL imaging lead.
Great, go to the next slide, please. I'll let you do the background, Ash, that's okay.
Yeah, thanks, Follow. So if I can just set the scene here, I think we're all critically aware that even before COVID hit us, that there was a significant gap in between capacity and demand when it came to, in particular, ultrasound, such that certainly as a group of NHS providers, we feel that our ability to efficiently turn around requests and provide timely scans has not been optimal. I don't think we've been providing the quality service that we would really desire to do that. And as a result, the NCL has been heavily reliant, certainly from primary care, on third-party providers such as in health. So this discrepancy became even more paramount after the first wave of COVID, when we had to literally just stop all our elective scanning. So as part of our recovery and transformation, there are two main objectives to improving ultrasound, the ultrasound service within NCL. The first is to increase our capacity And there are several work streams going on that are aimed at trying to address this issue. You'll have heard of several of them, like the Community Diagnostic Hub programme, which is about to start. This potentially will give us in NCL the option to bid for £6.6 million worth of equipment to improve diagnostics and certainly improve direct access diagnostics. We have a workforce team that have done a great piece of work for sonographers, allowing like an NCL passport so that sonographers can move seamlessly through different NHS providers. So you can better match capacity to demand. And we're also looking at creating an ultrasound academy later on this year. So those are some of the ways that we're going to try and increase capacity, although those are going to be slow burners, admittedly. But it's also incumbent on us as all clinicians to ensure that the capacity that we do have is used absolutely appropriately. So we've been working together in much more of an integrated way than I think secondary and primary care have worked before, which has been a pleasure, to really try and assure appropriateness. And what we've done is we've taken the National British Medical Ultrasound Referral Guidelines and modified them to NCL specific guidelines, taking into account existing NCL pathways. And the idea is to, as I've just said, is to give referrers a guide as to what they should and shouldn't be requesting, but also give them the clinical confidence to know that their decision-making processes are backed by NCL ratified guidelines. So that's basically the background of why we've done this. And it is about trying to provide the right test at the right time. It's certainly not about restricting general practice activity or referrals. And if a referral does not meet the criteria within the document, which actually, when you see it, are incredibly wide and actually broader than the BMUS guidelines, there is always an option for any referrer, as long as the clinical information is detailed enough to ask for an investigation that's, as we say, off-label. And there are, within the document, there are contact points. So we would encourage you to be able to email the providers for radiological advice when required. Follow, I'll hand over to you now.
So actually, if we skip the next, because Ash has covered most of the background, we'll skip to the next slide of this. So we won't go through the guidance in detail because it's many pages long, but look at the key principles and then pick out some clinical scenarios to describe and show how the guidance will be used in practice. So key principles revolve around clearly specifying the clinical question. So as Ash mentioned, clear clinical information is encouraged, and specifying a clinical question is important. So thinking about when you're ordering a test, what do you want the ultrasound to actually answer? What suspected diagnosis or differentials are you expecting? And providing enough clinical information to justify why, in this case, in your case, with your patient, that the ultrasound is the best test. So whether you're providing information from the history, examination, or lab results to support the possible diagnosis, it's important to give that information to the imaging team, because although ultrasound is a great imaging modality for lots of abdominal illnesses, there are some where it might not be the first appropriate first line test, or where this pathway might not be the most appropriate pathway, perhaps if it should be considered to be an urgent referral. So the guidance does include prompts to think about whether this is the best test, or is it potentially an unnecessary test which may not add or change to the management of the patient. In addition, the majority of ultrasound examinations are performed by sonographers who will benefit more from having clear clinical information and questions in the referral in order to allow proper interpretation of their findings. And as Ash mentioned, if referrals are felt to be incomplete, they would be returned for further clarification. And they won't just be returned and say, returned or not suitable. There is a standard letter template that all the providers will be using to inform clinicians when a referral has been returned and why it has been returned. And this will ensure that there's clear and consistent feedback given from secondary care to primary care when referrals are returned. And the referral template is also has specific sort of categories on it to try and encourage the imaging departments to give that detailed feedback. So it prompts them to say maybe the clinical information is insufficient, maybe a different referral pathway, such as an urgent pathway, is more suitable in this case, or whether the clinician could refer to existing clinical pathways via the NCL website, or if routine secondary care advice or referral may be more appropriate in their opinion. We'll have the next slide, please. So the guidance is not designed to restrict access, though, but to ensure we're selecting the right test at the right time for the patient, ultimately reducing the amount of referrals that may be considered unnecessary or not actually changing patient management or care will reduce the demand on the imaging services and then improve waiting times for patients who do need ultrasound scans and for whom it is the best test. The guidance does include, as mentioned, direct alternative services or referral pathways where appropriate. So we're trying to give another option if in this case, or if in your case you look at the criteria and you find that ultrasound may not be recommended, there are suggestions as to what other options you could consider in that case. But if you feel ultrasound is the best test, even if it falls slightly outside of the criteria in the guidance, clinical judgment and autonomy is encouraged, and giving enough clinical information that's adequate to support the use of ultrasound, posing a question is key. And if in doubt, contact the radiology department. So through this, we have been able to agree that the providers will provide contact details, an email address and a phone number for each of the hospitals and in health to use for clinical discussion before referrals or to discuss a returned referral. The email response time will be 48 hours or 42 working days, and the phone lines will be manned working hours 9 to 5, Monday to Friday. We'll also encourage clinicians to use advice and guidance when necessary. If the imaging departments feel maybe ultrasound is not the best test, we should be encouraging dialogue between the specialties as well to help decide on the best management plan for the patient.
Felicia, can I just stop you there for a moment? I think Arma has his hand up. Arma, do you have your hand up?
I do, but I can come in at the end once Felicia's finished.
All right, no worries.
Yep, that's fine. So the patient experience ultimately is what we're trying to improve here, and the patient journey is central to this work. And the aim is to getting the right test first time, reducing long waiting times, and avoiding scans that don't impact patient management. So one thing we wanted to also get across is effectively communicating this with patients, and managing their expectations is important to maintain patient satisfaction and that relationship. So if there are any doubts about a referral, communicating that to the patient that you're going to do a referral or liaise with the imaging department and get back to them or inform them of the outcome. Encouraging the rhetoric that this is to get the right test in the right time, and it's not that we don't want, you're being obstructed or restricted from getting a scan. And next slide. And finally, this is a live document. It's not set in stone with any newly implemented pathway. There are always teething problems initially, but we as a group will continue working on this and supporting the process, learning and adapting the guidelines to the needs of the users. We will be auditing return referrals and return referrals very soon in the next couple of months to look for or identify any areas where there's improvement or in any areas where there's education needed, whether it's in primary care or in the radiology departments themselves. And we'll also be conducting surveys directly to collect feedback from primary care clinicians on their experience of the using the guidance and liaising with radiology departments. But if you did have any questions or queries that you wanted to share outside of this like formal feedback process, then we really do encourage people to contact us. The contact details of the team will be at the end of the presentation and on the GP website as well. So all the data and feedback we will collect will be used to inform how the guidance is working and how we're going to improve it going forwards. I guess we can answer this question now before we go on to the scenarios.
Yeah, Amma, over to you.
Thanks, Polly. So I think our experience of having referrals sent back is you'll know it does create additional workload, both with patients representing multiple times afterwards and not being communicated with. So just to make sure that, you know, are we going to have a slick process by which patients are informed of the reasons that their referral is rejected, or is that going to fall on primary care to break the bad news?
That does fall on primary care actually to break the bad news. I guess one thing we should mention is most of the guidance is it does align with regular clinical practice that we should be kind of doing anyway, and we have made sure that the guidance does align with the existing NCL pathways that are available. So if we are using those pathways, hopefully more, and this is part of encouraging people to use, you know, the new NCL website, GP website, and the pathways. Hopefully, you'll be requesting an ultrasound scan in an appropriate presentation or appropriate patient anyway. But if you are concerned that we wanted just to encourage GPs, unfortunately, is on the primary care side to say, I'm going to contact the ultrasound department and see if they think this is the most appropriate test for you. It might not be.
Okay, just to follow up, I just, you know, it is going to create an increased workload. That might just be unavoidable. Another area of increased workload at the moment, I know this is not a focus on MSK ultrasound scan, but what is the future for MSK ultrasound scan from the Royal Free? I know there's a lot of pressure that was built up for ultrasound guided joint injections, but just want to make sure that that doesn't get forgotten, because that's where I feel the biggest restriction in
Yeah, I think Ash probably has more to say on that. For me, there's quite a lot more work going on there.
Yeah, so thanks, Armand. Nice to speak to you again. Just on your first point there, referrals that that don't meet the criteria, the information will be sent back to the GP, not to the patient. And that would give you some scope to re-refer if it's an appropriate referral. And actually, when you look at the guidelines, they, like as I've said before, they're not different to what you're already doing. And provided there's enough clinical information, actually the referral rejection rate, if we're going to use that term, should actually be low. So that will be interesting to see. With regard to MSK ultrasound, that's not included in these guidelines for the very reason that it's one of the more difficult areas to tackle, and the capacity in expertise to deliver the service and the demand is disproportionately high for MSK ultrasound. And the sector's ability to provide the service is also inequitable. So, for example, you'll know that in the past you've had direct access to the Royal Free, but you haven't had direct access to the Royal National Orthopaedic Hospital, where there are multiple MSK expert radiologists. So some of these things need to be addressed, but the way the sector is addressing this is that we want to approach this in the same way that Camden and Islington have been working, and that's by using an MSK, a clinical MSK service that primary care can use prior to direct referral for ultrasound injections. That's not to say that a GP with a specific interest and a declared interest as an MSK specialist, as it were, couldn't have access to direct access, but that would quality assure the service, and that's the where we're going with that.
So we can maybe go back through the chat and address some of the questions at the end.
Yeah, sure. Let's go to the chat at the end. Thanks.
So the next slide, please, is just looking at a few of the scenarios in clinical practice. I want to make this a bit interactive, so please use the chat or put your hand up to discuss any of these cases. So the first scenario is a 45-year-old female patient referred for an abdominal ultrasound. We've got 3 different referrals here, referral A, B, and C. So just if you have a read through and maybe suggest which ones you think are appropriate or justified and which ones are maybe not appropriate referrals.
Usma says B and C reflect the thought process of the referrer.
Yeah.
Georgia says C. Says C.
I'll see if anyone else. B, yeah.
Some B's and C's.
Yeah. Okay. Thank you for participating. I'll just go through them, and if you have any questions about the process and the guidance here, just ask and we'll discuss it for each case. So if we go to the next slide, referral A, abdomen pain query cause, and then tap twice, I think. Yep. So referral A doesn't clearly justify the need for ultrasound. There's not enough clinical information. There's no clinical question or potential differential diagnosis to suggest that ultrasound is the right test for this patient, because it could be abdominal pain of any cause that might not be a suitable modality for ultrasound to investigate. It could be a female patient with an abdominal pain history that's actually suggestive of an ovarian cause, so actually an abdominal ultrasound would not be appropriate, but maybe a pelvic ultrasound would be the best option. And there could be other history or examination findings that might suggest actually this isn't suitable for a routine ultrasound scan, but should be sent via an urgent or a 2-week wait referral. So again, it's all about including enough clinical information and clinical questions so that the imaging team and yourself is confident that this is the right test for this patient. Ultrasound particularly might not always be the best test for non-specific abdominal pain, and depending on the history and investigation and the clinical concerns, it might be better to consider other investigations or advice or referral to secondary care gastrointestinal teams. So the next slide. So referral B, one more tap, I think, is an appropriate referral according to using the guidance. Sufficient clinical information about history and examination and a question has been posed, and it's widely accepted. I think everyone agrees that ultrasound scan is an appropriate test to investigate gallstones. And the next one is referral C. So it does provide clinical information, which people did mention. It does have a history, examination, and some blood test results. But there isn't really a clinical question or differential, so it's not necessarily clear what the clinician is suspecting in this case and whether ultrasound would be the best test in this case. The guidance does prompt clinicians to consider malignancy where appropriate, and in certain patients with abdominal pain and loose stool, maybe that's something that should be considered, and clinicians should redirect to alternative pathways. But also for other differential diagnoses such as IBS or diverticular disease, then ultrasound might not be the best test, and the guidance redirects to other pathways such as the IBS pathway in these patients. Yes, so that's example number 1. Let's check if there's any question. So that was a female, so I'm just looking. Yes, not every patient can give a good history, but as long as you can include as much history as you have and the appropriate investigations and examination findings in your referral, as Ash said, and as we said, it doesn't mean that the guidance will block your access to ultrasound, but it's just making sure that you've explained why you think this is the best test for the patient at this time. So the next example is a thyroid lump, referred for a thyroid ultrasound scan. We've got 2 referral options there. So people could comment which one they think is an appropriate or justified, or yeah, maybe people vote which one they think is justified, if any.
Is this the physician's decision for the GPs?
Patrick says A.
I can't see any messages.
John says both.
Okay. Okay, next slide. So referral A and then is an interval scan for a known benign nodule. So actually the British Thyroid Association, along with the British Medical Ultrasound Association, advises that interval scanning of asymptomatic nodules isn't necessary. So in this case, there's no clinical additional information to suggest that anything has changed in symptoms or examination that may warrant another ultrasound scan. And in the guidance, you have included a prompt to advise clinicians of, if there is a change that might warrant an ultrasound scan, such as a change in size. But if not, they don't need to be routinely repeated scans. So more information is needed on that one. And in the next slide, referral B. Again, this is also needs a bit more information to make it clear that this is warranted. Again, the British Thyroid Association and the BMUS guidelines do advise that incidental finding of thyroid nodules do not clearly need routine ultrasound. And this referral also states exclude malignancy, and this pathway is not a pathway for suspected malignancy. If any suspected malignancy is considered, it should be going via a 2-week wait pathway. And here there's no additional symptoms or examination findings or clinical history to suggest that the thyroid nodules may be concerning, and we have included some things to think about if you do have patients with incidental thyroid nodules, in what situations or presentations it might be warranted that they have an additional thyroid scan, or where it could be left alone.
Follow. Hi, Tash here. I'm just cognizant of the time, and although these are great examples, I just would be really keen that we can answer some of the questions in the chat, and maybe take some direct questions from those GPs with their hands up.
Yeah, I think that would be a good idea, Ash. So Patrick has his hand up. Patrick?
I just wanted a clear make sure that we are still allowed to refer people for ultrasound guided query subacromial bursitis. Can you hear me?
Yeah, yes, I can.
Yep, Patrick. Ash, did you hear that?
Yes.
The main thing that I refer people for is they've got painful shoulders, quite clearly that there's something wrong. The pickup rate and the relief they get with ultrasound guided injections is fantastic. I used to do my own injections, but I've stopped doing that because it's better on ultrasound. Is that still ongoing, or is this part of the cutback?
I wouldn't say it's cutbacks, it's just lack of ability to deliver the service. You know, at the Royal, I can only speak for the Royal Free in terms of backlog, but we still have over 700 patients that need ultrasound guided injections. So that's why capacity is limited in that respect. The remainder of the NHS providers are open for direct access MSK injections, but as I said, the move in the future, Patrick, is to be able to refer these patients on to specialist physio services. When we've done our initial physio service assessments from GPs, up to 50% of patients don't require any further imaging or any further intervention and have been treated successfully with conservative therapies. The specific that you mentioned is one of those pathologies that does respond very well to steroid injection, as you say, but not all of the referrals are like that by any stretch of the imagination.
I know, I can see your point, but I mean, this is a really simple test to do. It takes about 2 or 3 minutes. It's very easy. It's, you know, it's a great service. I mean, sort of to cut that back, I think is.
It's not. We're not.
It means a long way for people who actually work. It's a long way to get referred to MSK. People are debilitated by it. People can get frozen shoulders from it, and I think sort of, you know, cutting down sort of maybe some frivolous referrals is missing a lot of people who actually need it.
So there's no cutbacks in the number of people delivering the service and able to deliver the service. But if you appreciate that, actually, if you can assure appropriateness, if you can clear some of the inappropriate referrals that are having those MSK consultants do needless or ultrasounds that won't actually change any management, then there is more room for the things that are totally justified and appropriate. That is the whole premise of this.
And I agree with you, because I have lots of patients coming in saying, can I have an ultrasound of my abdomen, please, doctor? You say, why? Well, I've got sort of various aches and pains. And I agree entirely with that. That's fine. And once a test comes up, people love MRIs in their back. People love ultrasounds of their abdomen. They're irrelevant to hear from their friends, and they want them done. And this is definitely one thing that it's beneficial and helps, and it's easy to diagnose and easy to treat.
Yeah, thank you.
Thanks, Patrick. Thanks for that. I guess it's about justifying it on the referral. Stephen Corcoran commented on a case where he was asked to image a pituitary in more detail by a radiologist, and when he tried to do that, the referral was rejected, saying that he needed either neuro referral or a consultant connect opinion, which obviously just wastes time and delays things. And we've had another comment from Eugene saying, repeat scan after interval, why not just arranged rather than asking GP to refer again? So both those questions are on the same line.
Yeah, so in answer to Stephen's question there, which is a very good point actually, and it's a frustration for you. I can totally get this, because it's not an uncommon thing for us to pick up incidental findings that require further imaging and in other modalities such as CT and MRI, which you don't have access to. And I think as a part of this program, if a radiologist does recommend that, then what we will do is we will give you as referrers the option to either allow us to book that directly or for you to intervene if required. And the reason why we need to be able to allow you as custodians of the patient to make that decision is because we don't have the clinical information. We don't have the full story and the background of the patient. We have no idea of the performance status of the patient. We have no idea of whether they're a candidate for any escalation in treatment. So, for instance, the pituitary case, we can't contextualize the radiographic significance of that, but possibly Dr. Cochrane could. So if you've got a 90-year-old, what's the point investigating for a pituitary macroadenoma? You don't need to. And the same goes with if it's something like a gallbladder polyp follow-up, that's something that we can do. But again, it would all be dependent on whether the patient is eventually going to be a candidate for any change in management as a result of that scan. That's why the more information that we've got on the request form, the better advice and more focused advice that we can offer.
Hi, can I just say something?
Go on, Patrick.
I've just had a request on an ultrasound for a repeat of a gallbladder polyp to be done within a year from a radiologist. I mean, just in the last time, I've just done the referral thing a few days ago.
So, Ash, what are your comments about asking for ultrasounds at a certain interval, so repeat ultrasounds for monitoring? Is there any way that can be done in secondary care rather than asking the GP to re-refer?
It's something that we can take back, but to the NCL imaging board for consideration, absolutely. But again, it doesn't. We don't have your knowledge of the patient. It's simply it literally is that. And not all patients are appropriate for clinical follow-up, although the advice from a radiological perspective is one thing.
No, I agree with you. I think, and a year is a very long time to sort of ask for a follow-up because people will forget them. The DNA rate will be very, very high. But if you send someone back to your GP saying, please repeat the ultrasound in a year's time, then when you request them, they shouldn't be refused, really, should they?
No, it wouldn't be.
That's fine. That's all. That's fine. Excellent.
They're well within the guidelines. It would never happen.
That's fine. Excellent. Sorry.
Okay.
Come in.
Thanks. A couple of Jonathan Lubens. I know you've posted a couple of comments, Jonathan, in the chat, so feel free to unmute if you want to. Jonathan says, will NCL ensure that ultrasound workers do not give inappropriate advice regarding further tests? Will they use the NCL guidance to ensure they give correct advice?
Yeah, I think you've hit on a very important part, is that you know, there are issues with the quality of service we provide, and you know, absolutely we'll need to address those. So I think if we're not giving you guys actionable reports, that's the stuff that we need to be fed back, and we'll do our best to change that. One thing that we've felt frustrated with is the lack of quality control over in terms of in-health, and there is a lot of duplication or perceived duplication between in-health scans and patients that get subsequently referred into secondary care. So a part of this would be trying to quality assure the service from both secondary care providers and third-party providers.
Thanks, Ash.
I think just to add one thing about the referrals being suggested by secondary care or radiology, I think we did discuss that if it's clearly put in the referral that this has been recommended by a radiologist, particularly if you have the name and you're sending it back to that trust, it will go back to the trust where that radiologist made that comment, and it will be looked at appropriately. So again, putting as much information as about why that's being requested is the key, so that it's not necessarily returned because they didn't know that their radiologist actually requested that repeat scan.
And one of the reasons why we really still want to allow GPs to be the custodian of care for these patients is because not every general practitioner wants to have a CT or an MRI report land on their doorstep. You know, the number of incidental findings for CT ranges between 10 and 40%, and about between 10 and 15 of those require further tests, referrals and workup, and therefore, you know, I've spoken to certainly you know, several GPs who would prefer, rather than to just send the patient into a secondary care environment, rather than take on reading and acting upon CT or MRI reports themselves. So I think, I'd really prefer to leave that up to the GP as to how they'd want to progress there. Send back to us, absolutely, we'll scan, or send into secondary care if you felt uncomfortable with dealing with the report afterwards.
Lovely. Thanks, Ash. Where we've gone over time, all the unanswered questions in the chat, Ash and Felicia, if it's okay with you, I'll send it to you via email, and perhaps you could answer them and I can circulate it at a later date.
Yep.
Any final comments or words from you both with regards to the guidelines before we wrap up?
If we could just go back to the presentation, just the last slide, which will be saved on the website, the contact details of our project managers who will be, maybe not the last slide, maybe this slide, yeah. We'll be taking feedback if anyone has any thing they want to share during the process of this now being live. And yes, also I think there was a comment from John about the NCL website. Oh, not from John, from someone about the NCL website.
There was a question about
I'm not involved in that directly, but I know that there is, because it's now being merged as one CCG, all the pathways are being reviewed. So some are sort of offline whilst they're being aligned across NCL, but hopefully that process will be happening quickly and everything will be up and running again as normal.
And follow, just before we go, can I just express my thanks to our CCG team, the programme team, because they worked incredibly hard over the last months with both me and the 5 GPs that have all been involved in this programme, and that's specifically, Nosh Khaja, Keith Spratt, Beth Dayhill, Stephen Wells. They've been fantastic.
Brilliant. Thanks to you both for joining us. That was a really comprehensive overview of guidelines, and you were challenged by some pretty tough questions. So thanks so much for addressing those. Any outstanding questions, I will circulate everybody. Nosh, do you have your hand up, or is that a historic hand? Okay, I don't know what Nosh does. Okay, everyone, so we've gone 5 minutes over. We're going to have to wrap up there if that's okay. Thanks so much for joining us, and thanks again to Ash and Felicia, and also to the Federation Medicine Management team and Training Hub team for their updates. We plan to continue these meetings monthly, and that will be on the first Wednesday of every month. So you can put those dates in your diary. There are lots of dates that are sort of TBC, lots of topics that are TBC for upcoming dates. So please, can you either post in the chat, or if it's easier, just drop me an email with any requested topics that you might like to have at Pan Barnet, any topics that you would enjoy, or any learning needs that you have in Barnet. Please drop me an email just so that we can get thinking about planning for the rest of the year. Lovely. Thanks, everyone. Thanks so much for joining.
Thank you.